Hello. Thank you for joining us. I'm here with Dr. Hammel. He is the head of cardiothoracic surgery at Children's Hospital Medical Center in Omaha, and he is doing his presentation that he also did with us during the 2018 SOF conference in Omaha on cardiac surgery in infants with trisomy 18 and trisomy 13. I'll pass it over to you, Dr. Hammel.
Thank you very much. I appreciate the opportunity. It was fun to give the talk. We had a room full of parents and some providers, and I think we had a good session. So it's a privilege to kind of revise that or re-give that presentation to have on your website. I'm going to talk about cardiac surgery in infants with trisomy 18 and 13, and I'll be talking some about preparation for and selection of procedures, and some about the procedures themselves, and some about outcomes. So I'll just jump in. As I think everyone in your community is aware, heart defects are very common in infants with trisomy 13 and 18. In 18, 85% of children who are born alive have a heart defect of varying severities. Most of them, though, in general, are of moderate or relatively simple complexity levels. Half the defects are a ventricular septal defect, so just a hole between the two ventricular pumping chambers. Many children have some complexity of where the aortic valve lets blood out of the heart, where it is partially posed over the right ventricle instead of over the left ventricle like it's supposed to be. Many children have some obstruction to pulmonary flow. They don't really have, from the cases that I've seen, they don't have the same kind of tetralogy of Fallot as other patients, sort of the general patient with tetralogy of Fallot, but they do often have obstruction at the pulmonary valve level. A smaller number have atrioventricular septal defect. Many have abnormalities of the aortic arch, the large vessel from which all the other arteries branch, and in at least 10%, there's some obstruction to flow through the aortic arch, but in many of them it's abnormally formed. And then a smaller number have more complicated defects where there's only one effective pumping ventricular chamber. In trisomy 13, a somewhat smaller number of the patients, or fraction of the patients, have defects, but they tend to be skewed a little bit more towards the complex defects. So to explain about the common heart defects, I'm going to start with a model of a normal heart. So this is a normal heart. Whoops, I went up. Okay, so this is a normal heart. There's a large vein carrying blue venous blood from the lower body and from the upper body into the right atrium, the right upper chamber. Blood flows in through this tricuspid valve into the right ventricle. The right ventricle pumps blood out a pulmonary valve into the pulmonary artery and out to the lungs. So there would be a lung on each side here. And then in the lung, the venous blood picks up oxygen, turns bright red, and then flows back through pulmonary veins on each side into the left atrium, left upper chamber, and then flows from there in through a mitral valve into, that keeps happening, into the left ventricle. And the left ventricle is the one that pumps to the body, out through the aortic valve, up the aorta, and through the aortic arch. And this is where the branches take off to the right brain and right arm, the left brain and the left arm, and then down the back to the abdomen and the rest of the body. So now moving ahead to ventricular septal defect, the most common and a component of many of the other defects. Ventricular septal defect means that there is a hole. Various kinds and locations of holes, but a hole between the left ventricle and the right ventricle. Now, what happens is in the normal newborn or in the newborn with trisomy, it is much easier for blood to flow through the lungs than it is for it to flow through the body. And so if you have a hole between the two pumping chambers, when the heart contracts, some of the blood in the left ventricle will go out the aortic valve out to the body, but it's easier for blood to actually flow through the hole and flow out the pulmonary artery to the lungs. And so when the baby is very first born and the lungs are still in the process of expanding, the resistance to flow through the lungs is kind of high. But in the first couple of weeks of life, as the lungs relax and mature, more and more blood will flow through the hole and therefore through the lungs. And by a month of age, lungs with normal resistance will have 4 or 5 or sometimes even more times as much blood flowing through the lungs as flows through the body with each heartbeat. And the heart compensates for this by gradually dilating and just pumping more blood. So if 4/5 of the blood is going to the lungs, then the heart has to pump 5 times as much blood so that enough blood will go to the body to supply the body's needs. Now, within the lung, all that excess flow causes problems. Firstly, the blood vessels, the arteries and veins carrying blood to and from the lungs, have to dilate to carry the excess blood flow. And then that crowds out space that should be available for air passages and air sacs in the lung and makes it harder for the infant to breathe. The excess flow and pressure can lead to swelling in the lungs or bleeding in the lungs. And then over the long term, the excess flow and pressure leads to injury of the blood vessels of the lungs, and they react. At first, they become just sort of spastically reactive, where they contract and release at times, but eventually, over the course of time, the increased resistance in the arteries of the lungs becomes gradually more permanent. Now, in an infant without trisomy, this process takes place over the course of years and remains reversible generally for a couple of years after birth. In infants with trisomy, both with trisomy 13 and 18, as well as infants with trisomy 21, the resistance often doesn't fall as quickly, and it seems to then begin to rise more quickly than in infants without trisomy, and it may or may not become fixed or irreversible at an earlier age than in infants without trisomy. So the concern is a little bit higher, and that requires some management. Now, anytime that you have a ventricular septal defect that's large enough, the pressure will balance between the two circuits. So more blood will just flow through the hole until the pressure evens out. And so the blood pressure in the pulmonary artery, when you have a large ventricular septal defect, is always elevated. And so we often see that the term is misapplied, that the patient has pulmonary hypertension. And I believe that it's confusing or misleading to ever use the diagnosis or the term pulmonary hypertension in a patient who has an open shunt between the two circulations, because yes, there is hypertension or high blood pressure in the lungs, but that's not what really matters, because even a child with perfectly normal lungs will have pulmonary hypertension, but if you fix the defect, they may have completely normal pulmonary pressure. So pulmonary hypertension as a diagnosis, as a term, should be applied to patients who have increased pulmonary vascular resistance. Pulmonary vascular resistance is how much pressure does it take to get a given amount of blood to flow through the lungs, okay? And so a child who has a large ventricular septal defect, although they will have high pulmonary pressure, they may have high pulmonary vascular resistance, or they may not. They may have low pulmonary vascular resistance, or somewhere in between. So what causes increase in pulmonary vascular resistance? So I mentioned that right after birth, when the lungs are all collapsed, the resistance is high. As the lungs relax over the course of the first month, the resistance generally falls. Things that affect the health of the lung often raise the resistance. So a respiratory infection, whether it's viral infection or whether it's pneumonia, will raise the pulmonary vascular resistance. Poor inflation of the lung because the child is weak or taking shallow breaths, or problems with the airway can cause increased vascular resistance. Parts of the lung that are totally collapsed have extremely high resistance and very little blood flows into them at all. It diverts into areas of the lung that are open. Aspiration or accidentally sucking either swallowed saliva or burped up gastric contents into the trachea and down into the lungs causes a lot of reactivity. It causes a lot of inflammation. And if that is chronically occurring, even at low levels, then that causes increased resistance in the lung. Pulmonary overcirculation, so this increased flow and pressure through the lung that happens as a result of a ventricular septal defect or certain other lesions, like for example a patent ductus arteriosus, also causes injury. There's a shear stress where the turbulent blood flowing through the arteries causes an injury, and it causes a signal that makes the artery constrict to sort of protect the lung from that high pressure. And over time that leads to vascular changes which are at first reversible but eventually become permanent. So just looking at this, this cartoon, a normal vessel has a lining of cells that are endothelial cells. These are active and they kind of control the contraction and relaxation of the artery. There are muscle cells around the outside, that that do the constricting, and then there's a tougher layer of adventitia around the outside. As the artery is injured, it develops more thickness of this muscle that both narrows the lumen or the area inside the artery, as well as gives it more reactivity and a tendency to constrict and relax more. And over time, you get more of this sort of fibrotic material in between the muscle, cells. And that combined with thickening of the lining and thickening of the outer shell leads to an artery that just can't relax. And then over time, as the lining, the intima, thickens more and more, the space inside the blood vessel for the flow of blood becomes smaller and smaller, and therefore higher and higher resistance. So ideally, any child with or without trisomy who has a large shunt lesion like a ventricular septal defect undergoes repair before these vascular changes are allowed to take place, or if their pulmonary vascular resistance didn't fall very much, then they undergo repair and then they receive treatment that's specific to helping the lungs to be more healthy and helping the resistance to fall. So for example, if they need airway support, if they even need a tracheostomy, if they need help with the mechanics of breathing or even a ventilator, if they need oxygen, if they need correction of problems that are causing aspiration or reflux, they get all these things, and then that allows the resistance to fall. If you don't close the defect, you leave it open, then you can do all of those things, but it doesn't really help, because if you treat pneumonia or if you treat reflux and then you lower the resistance in the lungs, you're simply rewarded by having more blood shunt through the hole and continue to pound the lungs. And so you never really can get ahead until the defect has been closed. Excuse me. Here are some surgical considerations that that we have experienced or run into in our experiences operating on children with trisomy 18. Firstly, the valves of their heart and even the tissues of the pumping chambers look a little bit different, both in person and on the echocardiograms. The valves that let blood into each ventricle, the mitral valve into the left ventricle and the tricuspid valve into the right ventricle, appear what we call dysplastic or just unusually formed. They have extra material attached to the leaflet of the valve. Oftentimes the leaflets are sort of redundant or floppy, but it's usually been my experience that at least at first, these dysplastic looking valves function well, and valve leakage has not been a problem early on. Now, over a longer period of time into adolescence, you sometimes see that the valves deteriorate in their function, and then there can be leakage. But that's not generally a problem early on. Second, as I mentioned earlier, the aortic arch is usually abnormally formed. That is, in the ideal state, it kind of looks like a candy cane, nice and smooth and round with branches coming off of it. But in kids with trisomy 18, it is oftentimes more irregularly shaped, and the branches are sort of inconsistent in their spacing, so it looks strange. But in general, many of those that look strange are not obstructive, and so we have to apply a little bit of careful examination to determine whether there actually is obstruction that needs to be fixed. Personally, I think that the incidence of obstruction of the arch is actually a little higher than some of the older literature indicates. I showed you at the beginning that the number of 10% has been published. I think that there probably is some degree of arch obstruction in a larger number, perhaps a quarter of those patients. Surgery in patients with trisomy 18 and 13 is performed at somewhat higher risk. Now, why is that? In general, the poor health status of many of the patients at the time they go to surgery is most of what's responsible. If the pulmonary vascular resistance is elevated at the time of surgery, even if it's reversible using oxygen or using a gas called nitric oxide, each of which helps to relax the arteries of the lung tend to be more sort of spastic and reactive, and an episode of reactivity, if the arteries clamp down, then that can suddenly put a huge load, a huge strain on the right ventricle, and that can be a life-threatening event. Infants with each of these problems are almost always born with low birth weight, and this means they have less energy, they're less robust, they have less reserve to recover from surgery. They tend to have had difficulty in feeding, and so if there hasn't been a careful effort to establish a safe route for feeding and good nutrition, then they may be malnourished and therefore also have more difficulty with healing. During the hospitalization where cardiac surgery takes place, oftentimes the infant is in hospital for a longer period of time than usual, and they may have additional procedures done. And some of those procedures then are kind of incorporated into the surgical risk. So if you have your VSD closed and then 4 weeks later you have a gastrostomy and a fundoplication performed, any mortality that occurs during or in the recovery from the gastric surgery is counted into the mortality of the cardiac operation in terms of people's reports. So that adds to the reported mortality. These patients often have difficult airways, often with a shortened chin and some abnormal shape of the airway down to the vocal cords, and that puts them at risk for difficulty with intubation, puts them at risk for failing extubation after surgery, and then each of these events, difficult airway, etc., is a time of high risk for instability and even cardiac arrest. They tend to have a less active immune system that predisposes them to infections that can occur in anybody after heart surgery, but which can be life-threatening in that setting. And then there's this issue of apnea, and while I'm sure that some infants with trisomy 18 and perhaps a somewhat greater number with trisomy 13 do actually have central nervous system dysfunction that causes these long pauses in breathing that are called apnea, I believe the majority do not. And what they do have, though, is that they do appear to be much more sensitive to drugs and medicines that can suppress the drive to breathe. So narcotics that are used to treat pain, for example, or prostaglandin, which is used to stabilize some newborn infants with heart defects. Both of these, I believe, lead to more apnea in kids with trisomy than they do in all the rest of our patients. So, you add these challenges together, you tend to have long hospitalizations before children are ready for discharge home, and the operative mortality that has been reported in the literature tends to be in the neighborhood of 10 times higher for a given heart defect than the mortality in a child without any trisomy. I thought I'd just show you a couple of pictures to give you an idea what cardiac surgery is all about. This view of a child, this happens to actually be a child without trisomy, and whose family gave consent for photography, by the way, I should add. So this operation is just beginning. This is the heart, of course. This is the atrium, or the upper chamber of the heart. Here is the ventricle, or the lower chamber. This being a child, there's very little of this yellow fat on the heart. I'm afraid my heart would be mostly covered in fat, and most of our hearts are by the time we get to middle age. These little things right here are the coronary arteries. Those are the ones that carry blood to the heart muscle itself. These are rarely a problem in children, but of course they give us trouble as we get older too. Now, the child has been given a dose of heparin to thin the blood so that it can't clot at all, and then tubes are put into the circulation. So this is a tube that goes into the inferior vena cava, carrying blood from the lower body, and a tube goes into the superior vena cava, carrying blood from the upper body. And they siphon out the blue blood coming back from the body, and then there is a, now I can't go down. There is, whoops, hang on, we'll get rid of that. There we go. There is a pump then, which sits next to the bed and is operated by my perfusionist partner. Blood comes down and it goes into this artificial lung here called an oxygenator and picks up oxygen, and then it's pumped back into another tube. Now I should be able to move it. Why am I not moving it? Pardon us, we're having technical difficulties. There we go. It's pumped back into this other tube then, which is placed into the aorta. So when the circulation is started with the pump does all the work of the heart and lungs. The ventilator can be turned off, and then the heart can be stopped and opened up so that you can work inside. The other tubing that you see here are other circuits where we can pump blood that includes medicines and electrolytes that stop the heart so that I can work inside of it. There are tubes here that are connected to suction handles up at the surgical field so that when we open a cardiac chamber and blood is spilling out, we suction that blood up and filter it and then pump it back into the child. So that's some of the complexity that you see here. So what are the results of surgery for congenital heart disease in trisomy 13 and 18. This paper came out recently, published 2017, and I think the results that were published here surprised a lot of people. Now, I mentioned that the survival within the hospital, survival to discharge from hospitalization for surgery is much lower than you would expect in infants without trisomy due to their much higher complexity. Survival after surgery for a VSD in general has tended to be in the neighborhood of 80%. But this graph shows what happens to the patients who survive to discharge. How long do they live fundamentally? It's been long published and taught to medical students that these children rarely live beyond 1 year, et cetera, et cetera. But this shows if you survive your operation and go home that 50% of children with trisomy 18 will be alive 16 years after they're sent home from the hospital. And the survival numbers are even better for trisomy 13, although it's a much smaller number of patients, and so that's why the line looks a little bit more chunky. But I think these numbers are quite a surprise. And when we shared this data with doctors and nurses at my institution, that's, I think, when the light began to go on for us that that there was really much more potential benefit in active treatment for these children, because there really was the potential of very meaningful survival after surgery. In fact, it's really hard to understand the pessimism about surgery for children with trisomy 18 when you consider how much enthusiasm there is for another specialty that we have at Children's in Omaha, that we all feel great about, which is heart transplantation. This graph showing median survival of children discharged with heart transplant shows the effect in the attrition of patients due to rejection or infection and other medical problems that occur after heart transplant. And if you look, 50% of patients are still alive at 16 years, exactly the same as survival after surgery in children with trisomy 13 and 18. And so it's really a striking similarity, and look at the difference in how the two activities are perceived. What about ECMO? ECMO is sometimes talked about. ECMO is an acronym for extracorporeal membrane oxygenation. It's a simplified version of the heart-lung machine I showed you earlier that we use for open heart surgery. This is a closed circuit, but it is used when you put tubing into a patient's artery and vein so that you can draw out venous blood, put oxygen into it, and then pump it back. And you can pump it back into the vein if it's only the lungs that aren't working, or you can pump it back into an artery to substitute for the function of the patient's lungs and heart. And because it's a closed circuit, you can be connected to this for a much longer time than the open heart circuit. This treatment can be applied for a period of weeks, and it can be used when a patient is failing after heart surgery, if their heart isn't pumping enough blood or their lungs aren't working adequately. And it can also be applied very rapidly in a child who's had cardiac arrest if they're not responding to ordinary resuscitative measures. It is an operation. You have to make an incision on the neck or on the leg, or if they've had heart surgery recently, then you can just open the chest incision and put the tubes in directly, but it's an operation. It is highly invasive, and it does use a lot of resources. There's lots of blood transfusion necessary, lots of medicines. It requires an additional technician just operating the pump 24 hours a day, in addition to the nurses and doctors that are caring at the bedside. But it keeps the child alive, and it immediately provides oxygen and blood flow to the lungs, to the brain and to all the other organs until you can figure out and hopefully reverse whatever is wrong with the heart. ECMO is a last line therapy for a child who is not doing well, and as a result, not everybody survives, and only about 2/3 of the patients who are sick enough to require connection to ECMO are able to actually survive and be weaned off of it. And of them, because they were so sick, many go on having difficulties, and only somewhat less than half the patients are actually able to survive to be discharged from hospital. However, it can be life-saving because, as I said, if a child is having cardiac arrest and not responding, by the time you can connect ECMO, then that's probably a child who's not going to come back with that ordinary CPR and is going to die. And so if half of those can be gotten to survive to discharge, then that's a lot of patients. ECMO is interesting. It's one of the lines in the sand that is drawn when programs talk about what they will or won't do, or what they do or don't think is appropriate for a category of patients. And we haven't used that philosophy in our program because I think that it's a powerful tool, and if one is going to perform heart surgery, then one should really apply all of the tools that are at one's disposal to achieve the desired outcome. The outcome that the parents had in mind when everybody decided we were going to go ahead with heart surgery in the first place. As long as that outcome is still achievable, we apply whatever tools are necessary that are available to us, and ECMO is certainly one of them. So I've mentioned some pessimism and I've mentioned some resistance, but I'll tell you too that there are publications that show that the trend is turning. And this is a report from a single center, but a report of a pediatric cardiac network where these bars represent only patients who were referred to the network. So this is a network for cardiac care. This does not include infants where no cardiac care was recommended and where they never came in the care of a cardiac physician. But of the patients who were referred for cardiac evaluation and possible treatment, red bars show the infants where a decision was made not to do any intervention, and blue bars show those where intervention was pursued. And as you can see, red bars predominated before 1980, and then the trend gradually reverses itself. And again, of the ones referred for cardiac care, all the patients in this particular network in the decade 2000 to 2010 did receive an intervention. So the trend is changing in that direction. And then of the interventions that were performed, that an intervention may be corrective, which means that we're doing everything that could be done to achieve a heart that functions physiologically as normally as possible. Or it could be palliative, which means we're doing a limited procedure which is aimed at trying to improve the function of the heart and lungs, but not attempting to actually establish normal cardiac anatomy and function. And what this shows, this is specific to trisomy 13 and 18, and what it shows is that patients who underwent a corrective approach, even though that means generally that they needed open heart surgery as opposed to closed surgery, and even though it means a higher operative risk, this graph shows that the long-term survival of patients who did have corrective procedures was significantly higher than those who only had palliative procedures. So again, this is similar to the ECMO question. If you're going to do something, why are you going to limit your procedure to something that's merely palliative? Life's tough with trisomy 18. Shouldn't we give you the best operation that we can give you and set your physiology up as well as we can do it? And this graph would show that, yes, that is the correct thing to do. So as a hospital and as a multidisciplinary team, this is a kind of a new enterprise for us over the last few years. And I believe that we have encountered a significant unmet need in the community. The national community of families who are caring for children and treating children with trisomy 13 and 18. And we've learned quite a few things. We've learned along the way that there is oftentimes a certain animosity towards patients with trisomy, and it's hard to understand. You see this in the literature, you see this in medical textbooks, and you see it in the opinions and attitudes of many practitioners, that it's beyond, for some reason, it's beyond pessimism and beyond merely not being optimistic. You know, if a child has a really severe cancer, we can be unhappy, we can be, you know, upset that they have it, and we can go and commiserate with the family, and obviously it's a sad situation, but there seems to be almost a rush to prevent care for the child with trisomy. And I can only call it animosity. I think that that's going to change over time as people see that not only are good outcomes and good survival possible with surgery, but also that if you take care of the children, they can live. If you don't, then their death is a self-fulfilling prophecy. But if you take care of them and they do live, then you also get to see how they grow and develop over time and what kind of a role they can play in a family. And I think that as we see more and more children growing to, well, infants growing into children and even young adults, I think that we'll learn more, and I think attitudes will gradually evolve. We've learned that pulmonary hypertension is often treatable. As I said, there are lots of causes of pulmonary hypertension besides just the overflow, and a child who is, let's say, several months old, where pulmonary vascular resistance seems to be just as high as the systemic or the body resistance, can receive treatment to optimize their ventilation and minimize their aspiration risk and optimize their nutrition, and then you can see that resistance fall. But what's necessary then is to capitalize on that moment and eliminate sources of shunt, close VSDs, fix the defects so that the pulmonary vasculature is then protected from that high flow and pressure. And then you really come on with your treatments for pulmonary hypertension, including medicines that specifically relax the pulmonary arteries, and then pulmonary hypertension can recede. And over the long term, we've begun to see patients who had systemic level pulmonary hypertension end up with pulmonary pressures that are normal or nearly normal. Now, I need to temper that a little bit. There does come a point where pulmonary vascular resistance is fixed, and where fixed as in unchanging, and where it will not fall to below a level that makes it safe where you can close defects. And in those cases, the approach to care and the approach to surgery needs to be a little bit different. I like to say, though, that there's always a best thing to do. Sometimes the best thing to do isn't to close the VSD, but there is always a best thing to do. And if a patient like that, for example, has leaky valves that are interfering with how the heart pumps, or if they have maybe their ventricular septal defect is affecting the function of the ventricles, or it's affecting the function of the valves, then some form of surgery may be beneficial for that patient, but at some point it may not be able to be a fully corrective operation. We've learned that central apnea is much more rare than it is taught to be in our medical literature. It certainly occurs in some patients, but there are other causes of apnea, and there are definitely many other causes of poor ventilation in these children: infections, airway issues, etc. And so to say that there's no sense treating any of them because they just don't breathe is just erroneous. We've learned that a multidisciplinary approach is really key. Our little team here in Omaha consists of a neonatologist, an intensive care physician, a physician who's a specialist in palliative care and chronic diseases, a geneticist, a specialist in pediatric airway, and a pediatric cardiologist, and myself as a pediatric cardiac surgeon, and a pediatric general surgeon, because we know that most of the children have at least some difficulty in all of those domains, and at a very minimum, all of those domains need to be completely evaluated. And so people often are fixed on the cardiac disease, for example, but that's never adequate to treat that in isolation. And it's a multidisciplinary approach to all of these systems that leads to the best outcomes in hospital. And it's not like that small team that I just named for you can do it all by itself, but within an institution it's really important that you have at least a nucleus of champions for these kids and for their problems, and then they can sort of lead the way and share their enthusiasm with the institution. We know, we've learned, not just in trisomy, but in all situations, that surgery can be very important for the family. And of course our objective is to have the child live in every situation and have them have the best outcome possible. But if nothing else, and this is never the only reason to intervene, but if nothing else, the simple fact of having evaluated carefully and presented all the options and then selected an option together with the family through a process of shared decision making, and then carried out that option, even if the child doesn't survive, that process can be far more psychologically healthy for the family because they're going to live a long time, and what happens with that child is going to be with them for a long time. Excuse me. And finally, we've learned that, pardon me, we've learned that surgery can be really an ennobling or a great experience for the team, for the hospital team, not just for the family, not just for the patient, but within our own institution. At first there was sort of hesitation and some pessimism, but as our nurses and docs got to know the patients and got to know the families, it really is a great example of what we were all after, when we went into healthcare. You know, an opportunity to really be of service to people who are in need. And that's what we're here for. So, you know, the animosity is a little hard to understand because, you know, as I sort of jokingly, flippantly say, you know, it's really no skin off my back to operate on these kids. It's an afternoon in the OR. And so why wouldn't I? And why wouldn't the team really, why wouldn't a hospital provide options and provide care? It's what we do after all. And we have, you know, as a treatment facility, as a treatment team, I think that this has really enriched our practices overall. Taught us a lot about families and difficult decision making and the positive effect that has for both for them and for us. So I think that's all I have to present today. Thank you very much for the opportunity to address you, and yeah, good day.
Thank you so much, Dr. Hammel. And as we can all tell, it's no question why families are increasing in number trying to seek you out. And we really appreciate all that you have done for our community.
Thanks.
Thank you.